This is David Harden from Minneapolis, Minnesota, and I want to talk to you about next-generation collagen cross-linking. I have done some research and consulting for a few different companies in this area, one of which is Avedro, which has a UV light system as well as riboflavin drug delivery system. ESI, which makes the Keraflow, which we utilize for delivering the riboflavin or the Photrexa solution to the cornea so that we can deliver it through the lids closed, as well as some other companies that have refractive surgery technology and also corneal technology. And cross-linking has rapidly improved over the last several years and become available to us in the United States. And so it is very pertinent to think, well, what kind of improvements can we make in the cross-linking process? And I want to talk a little bit about some of the things that are currently being worked on in cross-linking, as well as where some of this may go into the future, as well as where the technology is right now and what we should be thinking of as we approach our patients that have keratoconus or corneal ectasia. One of the goals in keratoconus is to try to prevent visual loss. And this really depends upon diagnosing the disease early so that we can stop that progression as early as possible through collagen cross-linking and also other risk factors such as rubbing and face sleeping. And in the past, what we used to think of is really just having the patient wear contact lenses until they progressed enough they couldn't wear contacts, and then we would do a corneal transplant. But really nowadays, if we can find these patients early, if we can then cross-link them, we can stop the progression and therefore prevent corneal transplant, which obviously has a higher risk and longer recovery. And so we'd like to try to prevent that if possible. But that means diagnosing it early so that we can stop the progression through cross-linking. I want to talk a little bit about the current approved process in the U.S. Like I mentioned earlier, Avedro has the Photrexa drug solution and a UV light source that allows corneal cross-linking. It's been approved now for a few years in the U.S. In summary, what we do is remove the epithelium, and then after the epithelium has been removed, the eye is propped open. We deliver riboflavin drops onto the cornea until it's saturated through the corneal stroma. And then the light delivery system is oriented over the surface of the eye, and then for 30 minutes the UV light source is delivering energy to the surface of the cornea and the corneal stroma. And then the patient is treated postoperatively to try to heal that epithelial defect as quickly as possible in this approach for corneal cross-linking. Obviously, this has some challenges. One is it's a relatively lengthy treatment. It'd be nice if it was shorter. We'd also like the procedure to be more comfortable for the patient, and we'd also like the recovery process to be easier in that there's an epithelial defect, and we have to get that epithelial defect closed. And during the time period that that epithelium is open, we have some risk of infection and corneal haze. And the patient is uncomfortable during that portion of the treatment. We'd also like the procedure to be effective. I think our current effectiveness is actually quite good, and so we just need to try to see if we can improve the speed of the procedure itself as well as the speed of the recovery for that patient. So in cross-linking, can we make it more effective? Are there other medications? Are there other delivery processes? What about oxygen? We'll talk a little bit about that. There's some thoughts on pulsing to try to raise oxygen levels. We'll talk a little bit about where that's at in the U.S. And also outside the U.S. Can we accelerate the treatment, make it faster? Can we potentially make it more comfortable? Can the eyelids be closed for a portion of the delivery for that medication? Is it possible to prevent epithelial disruption? Can we go transepithelial with our treatments? Again, can we make it faster for the actual UV light delivery system and also, again, for the drug delivery? And can we have a titrated effect where we get different contraction of the tissue in the areas where it's steeper? So are there combined treatments that might be able to be utilized to improve the shape when we're doing our cross-linking, or before or after the cross-linking? And what about long-term management of these patients? I talked a little bit earlier about identification, but also how often do we follow them? Is their keratoconus really cured? How do we make sure that they don't start to rub their eyes again? How do we control allergies? What about their sleep position? So oftentimes these patients will have sleep apnea. They'll sleep on their face and put pressure on their eye overnight. And so we utilize a lot of counseling. We send them for sleep apnea testing, and also in annual visits, at least annual visits. We'll instruct them, ask them about whether they're still rubbing their eyes or whether they've been able to stop that. How about software improvements in diagnosing the disease early, and then also in being able to follow that? We'll talk a little bit about that as we go along. One of the things in comparing different studies for collagen cross-linking is the analysis of these groups of patients is very difficult. So it's a variable patient populations are oftentimes studied. So if you have a real early keratoconus patient versus a real late keratoconus patient, one that's very young, one that's older, those things confound our ability to directly compare the populations of patients that are studied in various different cross-linking protocols that look at things like epithelium on or epithelium off, or accelerated or longer traditional type treatments. And so that's something that challenges us in trying to identify how can we make improvements in the collagen cross-linking process. What is the endpoint that we're really looking at? And when I talk to my patients, I think with the current system, we can really pretty much stop progression in almost everyone. And the patients I've seen still progress are those that are really very active eye rubbers that just have not stopped rubbing their eyes, have not stopped sleeping on their face. And so again, I think the genetic component of it, the structural integrity of the cornea, I think is very effectively handled with our current cross-linking process. But part of the challenge is really keeping those patients from causing more problems with their eyes by rubbing or by sleeping on their face. What about flattening of the cornea? So in a patient that has a very steep cornea, we may want to flatten the cornea. So how well does the collagen cross-linking process do that? And so those are things that are analyzed in the different studies. And there's multiple factors in the treatment parameters that we'll go through as we talk about things that I think are into our next generation. So the first one that we want to talk about is the speed of the cross-linking, and the terms that have been used are accelerated and traditional. Accelerated basically is trying to do this treatment in faster than the 30 minutes of light delivery. So is it just an amount of cross-linking? For example, the current treatments are 3 milliwatts per centimeter squared for 30 minutes. If you use 30 milliwatts per centimeter squared for 3 minutes, is it the same? How do you analyze that? Or if you kind of overcook it, is it more like what happens with popcorn when you take a higher energy and you cook it for a shorter period of time, you burn it versus the regular popcorn process? And so how do we analyze that? And there's probably some happy medium, and that's been looked at in various different clinical trials. This paper that was published in IOVS in 2018 did a meta-analysis of an epithelium off versus the processes that looked at conventional versus accelerated processes, and basically there were no statistical differences in the other parameters, other than there was a greater reduction in Kmax with the conventional treatment, and there was a greater decrease in the central corneal thickness in the conventional treatment than the accelerated treatment. And so this suggests that there may not only be just a photochemical approach or photochemical analysis or photochemical effect, I guess, but there's some other biological changes. And obviously, the various different parameters, again, it's somewhat difficult to analyze the actual studies, but we have a lot to learn about what's the optimum balance of energy versus time in this group of patients. So there's also other agents that have been used for collagen cross-linking. So the current system is riboflavin and ultraviolet light, but there also have been photosynthetic pigments and near-red illumination that have been studied in the past, rose bengal and green light that have been studied, femtosecond laser and riboflavin, formaldehyde, glutaraldehyde, genopin, and beta-nitroalcohols. And again, at present, it seems like the best agent and process is that of soaking the cornea somehow with riboflavin, and then an ultraviolet light delivery system to create that cross-linking, to create those strengthened bonds in the cornea. What about oxygen? What's the role of oxygen? What's the role of riboflavin concentration? So what happens is during the ultraviolet light delivery, oxygen's rapidly depleted during that ultraviolet light delivery, and the oxygen is necessary for the cross-linking process. And so higher concentrations of oxygen and pulsing appear to allow a more rapid cross-linking effect during the procedure itself. And there's some trials that have been done to try to analyze the various different effects of this and trying to figure out, what's the ideal concentration of oxygen in the corneal stroma? How do you get it there? By potentially even increasing the concentration on the surface of the eye. How fast do you pulse the light? How long does it take to recover the oxygen levels in the cornea? And is there a relationship with the concentration of riboflavin in the cornea? Is riboflavin used up, for example, in the cornea? And these are all things that are obviously important in trying to help us to get the patients to be able to have a strong cross-linking effect in as short a period of time in as safe a manner as possible. So the riboflavin delivery is also critical. How can we make it more comfortable? So this video here shows the Keraflow device, which is made by ESI, website's listed there, that basically uses this shell and sponge technology to go underneath the eyelids so that the patient can keep the lids closed. And then basically through the tubing, small amounts of riboflavin are delivered to the surface of the cornea. So you can keep the eyelids closed during the entire loading procedure. And we found that this allows a quicker loading of the drug because of the fact that it's not as diluted by tears. It doesn't run off the cornea when you add a drop and then close the lids, or a drop and then leave the eyes open. And so it allows the patient to be more comfortable because the lids are closed. The technician, it's easier on the technician because they don't have to constantly put another drop in and manipulate the eyelids. They basically just use the syringe that has the riboflavin solution in it and slowly push small amounts of the riboflavin through the tubing to deliver it through the eye. So that eyelid closure for the delivery of the medication by using Keraflow is more comfortable for the patient than what we've had traditionally, as well as easier on the technician. So what about combination treatments? So can we make refractive shape changes at the time we do cross-linking? Some of it happens by cross-linking alone, so it seems that the steeper areas of the cornea actually contract back more or flatten more. So that's something that happens just naturally. But there's also some analysis going on and some studies going on of using things like infrared light or heating or thermal contraction of the cornea to try to contract the collagen, or even using excimer laser tissue removal. And one of the concerns with the tissue removal by the excimer laser or reshaping or PTK at the same time or before or after collagen cross-linking is that if you do get the cornea too thin, there's probably some relationship between the thickness and sort of the internal strength per unit thickness that could be violated and actually worsen the problem. So this is similar to if you have a tire with a thin sidewall and there's ectasia or bulging of that tire. If you thin that tire more, then basically it will actually worsen by, you can't really get it even with the rest of the tire by thinning it out. What about addition of tissue or materials? So, for example, Intacs is one of the ways that we've utilized in the past to try to improve the shape of the cornea, and we usually do that at the time of the collagen cross-linking if we feel Intacs are helpful or necessary. But there are also other biologic materials, corneal stroma, etc., that can be inserted into the cornea to potentially change its shape or augment the strength of the cornea. So I'm going to talk a little bit about kind of where I think we're at even now and things that you can do. Obviously, we have a very effective treatment now with our traditional Avedro system of epithelial removal, delivery of the riboflavin, and then ultraviolet light. So it's not like we have time to wait for future treatments, for example, because of the fact that this is a progressive disease and these patients can get into big trouble within a short period of time. So how do we diagnose it early? So this is a 9-year-old that has some slightly asymmetric astigmatism. So the question is this keratoconus or not? And on this first exam, I wasn't especially suspicious of keratoconus in this patient, although they do have slight asymmetry, and there is a little bit of thinner cornea inferior-temporally, so I think it's something to watch this patient very closely. And so I checked their topography and tomography. On the left is a picture of the Humphrey topography, and on the right is one of the eyes with Pentacam technology. And I followed this patient every 6 months and basically gave instructions as far as things like eye rubbing and allergy control to try to minimize any other additional impacts. But obviously there are some patients that have progression even despite modifying those other risk factors just because of the genetics of their corneal stroma. And so we basically watched that patient now over 2 years and 6 months apart for various different examinations. And so far that patient's been very stable. And sometimes it's very difficult to just look visually at serial topographies or tomographies to see if we think it's stable. And so one of the things that's very helpful is on this exam here, the Pentacam can do digital subtraction analysis between 2 different exams, and you can do them for the 6 month apart ones, you can do them for, say, 2 years apart. So you just select the ones you want to compare, and it'll basically subtract them and then give you a difference map. So on the 2 different screenshots here, you see the corneal topography, but you also see then a difference map. So that's one that's mostly green with maybe a little bit of blue on the one that's on the right-hand side of your screen. And those are showing that the subtractions between those two show no difference in the corneal curvatures for this specific patient. So you can pick up more subtle abnormalities and changes, and so if you're not real sure if that patient truly has keratoconus, then you can potentially just see them back again and at whatever time point. This patient's pretty young, so I chose a 6 month time point. If they were 15, 16, 17, for example, you might choose 9 months to a year, and so you can follow that patient over time. This is another patient. This is a 14-year-old, and I felt like this was definite keratoconus. And a couple years ago, they had a normal eye exam. They did not have topography at that point. They had a minimal refractive error at that point that was well corrected when they had their eye exam a couple years ago. But obviously now their best corrected vision, it has dropped. They have irregular astigmatism and a pattern consistent with keratoconus. And so this patient really needs cross-linking because we want to do this now because you don't want to wait for additional further progression that might make it more difficult for that patient to have reasonable vision in glasses or into a contact lens and potentially eventually end up with keratoplasty. So So we don't wait for true progression if there's a history of the patient being normal and there's not some other underlying condition, and the topography is obviously that of keratoconus, as this one here is. So, well, how far can we take cross-linking? So there are some patients where the cornea is extremely thin. They cannot get good vision in even the best attempts at contact lenses. Contacts have dramatically improved over the last several years. Scleral lenses have really been fantastic for managing this really tough disease and some really tough corneas. But there are some, as shown here in this patient's topography and tomography, where you really can't get good vision. So this patient had about 2200 vision, even in the best contact lens fit. And these are ones where you really just need to do corneal replacement for vision. And basically this patient went on to have a deep anterior lamellar keratoplasty with femtosecond cuts or edges on the cornea, and that's my favorite approach for this group of patients is lamellar keratoplasty. If I can separate that Descemet's membrane, because it just reduces the chances of rejection over time, and so that I think that's a much better option for the patient. But again, there are some that just can't be handled by cross-linking, and again, hopefully in the future we'll have other additional technologies, but some of these patients just may not be able to have cross-linking, and that's why, again, it's just very important to identify this group of patients as early as possible in their disease problem. What about ectasia after LASIK? Again, there are some patients that develop ectasia and they maybe were progressive and maybe not. Most of the time I really concentrate on other risk factors there, like rubbing, and how do you identify whether they're at risk of ectasia if you're looking at a patient preoperatively before LASIK or PRK. Those patients that are at higher risk have an unstable refractive error. They may have a slightly skew radial axis on topography, and they may or may not have had progression. So this is that same patient that has slightly skewed radial axes. Even though they're stable, this is a patient that still probably has some extra risk if you thin the cornea. Eye rubbing and sleep apnea, or sleeping on your face, rubbing your eyes, putting pressure on the eyes overnight, all potentially are things that increase the risk of ectasia with refractive surgery or even without refractive surgery. And so this is a group of patients that you want to look at carefully. We found collagen cross-linking extremely helpful for patients that have corneal ectasia after refractive surgery. And again, the problem is oftentimes that the patients come in fairly late with the ectasia where they already are in a contact lens. So the earlier we identify that group of patients, the better off we are. Here's just another way of trying to follow for progression. This is the ABCD map, and this is present on the Pentacam, and it uses the visual visual acuity as the D, and then the corneal thickness as the C measurement. You can track these over time, and then the back curvature, back elevation of the cornea, as well as the anterior elevation. So that's basically the ABCD. And this actually has some statistical parameters that can show you what the standard deviation is between exams in someone that would be normal and in someone that has keratoconus that has progression. And again, and this can be useful both preoperatively but also mostly postoperatively. And I tend to use those subtraction maps that I showed you earlier, comparing various different exams to try to decide in a borderline case, do they truly have keratoconus or not, and then also to follow these patients postoperatively. So in summary, cross-linking is really excellent right now. And even though we think, okay, there's something better coming in the future, and there likely is, it's something where the way that we are currently doing collagen cross-linking works well enough, is comfortable enough, can keep the patient from developing progressive ectasia potentially needing a different format of contact lenses, for example, going from a soft to a hard, or even needing a corneal transplant or penetrating or lamellar keratoplasty. So any patient that has keratoconus, even if it's extremely early or has ectasia after previous LASIK, really would benefit from reducing that tendency for progression by collagen cross-linking. Identifying that group of patients early is really, really important now, and the technology is rapidly improving. I think we'll have something better in the future, but our current technology, again, works really well. And most of the attention is really trying to improve the efficacy as well as the safety and comfort. And so methods that can reduce the tendency to have epithelial defects and speed that recovery, ways that can make the delivery of the drug more comfortable. So, for example, the CareFlow device, by being able to keep the patient's lid closed and reduce evaporation, dehydration of the cornea, and make it easier on the technician. Improvements in the speed of the UV light delivery through things like pulsing and higher energy levels, again with some caveat that there's some limit as far as how high the energy can be and how long the duration needs to be for it to actually be impactful. And again, trying to get the drug through the epithelium, making sure that the epithelium doesn't provide a barrier to the ultraviolet light delivery system are all also important. And so I think we should look forward to those new technologies and that next generation of collagen cross-linking. Again, this is Dave Harden from Minneapolis, Minnesota. Thank you for your attention.